tonight because we are here to cross all the globe. So on the behalf of the Pain and Pain Management Committee of the WFSA, the World Federation Society of Anesthesiologists, I am here. I am Dr. Gohar Afsha. I am the professor and consultant of anesthesiologists and the pain physicians. And currently I'm a member of this committee. And now this webinar, which is the first webinar, and the title of this webinar is Pain and the Pandemic, the Global Perspective. This is the first webinar of our series. And before I start the session, I would like to call Dr. Claire Rocks. Dr. Claire Rocks is a consultant and the pain specialist working in the NHS in the UK and chair of the WFSA Pain Management Committee. She has interest in the global aspect of the pain management with a PhD in his field and has led many essential pain management program, the EPN program, across the world. So I would request Claire to introduce our activity and our future plan on the behalf of the WFSA. Claire, please.
Thank you very much, Gauhar. So as you said, my name's Claire Oakes. I'm an anaesthetist in the UK and the chair of the WFSA Pain Management Committee. Just to let everyone know, we are recording this webinar. Do let us know if you have any problems with that, but we'll be recording it and we'll hopefully be making it available for future use. As Gauhar said, this is the first of the webinars that we've ever put together. So hopefully we have it'll run smoothly, but we have had a few technical challenges on the way. We're hoping there will be several more, and we will obviously keep you informed of those as they come through. Thank you all very much for attending. I know it's a Saturday and many people have lots of other commitments. So thank you very much for being here. Thank you especially to Jay at the WFSA and the rest of the admin team there who've been invaluable. Anyway, we will keep things moving. We're quite short of time, so I'm going to hand over to Gauhar and the rest of the panelists. We've got a great set of panelists here who I hope will be sharing some of their experiences of what really has been quite an extraordinary few months for absolutely everybody around the globe. And it will be fascinating to see how everybody's been affected in such a different way. So thank you very much, everybody, and we'll enjoy.
Thank you very much, Claire. So very briefly, I will talk about today's activity, the webinar activity. So we have two very interesting panel discussion. The first panel discussion is about chronic and cancer pain. We have 3 experts and across the globe, and we have one moderator. And the second session again is about the acute pain and the COVID and suspect and COVID confirmed patients. And again, we have a 3 panelists and 1 moderator. So for the first session, which is the managing pain in cancer and palliative care patients, are we heading towards the right direction during pandemic? Now, this is a panel title, and the moderator for this session is Anna Schwarzman. So just very briefly about Anna Schwarzman. She is an assistant professor in the University Hospital, Oregon, South America. She's a pain and the palliative care consultant in Buenos Aires, Argentina. She's a secretary of the Latin American Society of Regional Anesthesia. Her special interests are in teaching in acute pain, chronic pain, learning programs, and ultrasounds for regional anesthesia and pain medicine. So hand over to Anna for your very thrilling session, which is managing pain in cancer and palliative care. So Anna, please.
Good morning, good afternoon. Thank you, Gauhar, for the presentation. Great pleasure for me to be here this day, moderating this session about chronic oncological pain during the pandemic. I will briefly introduce the 3 panelists that will
Anna, I think you may need to put your video off. Oh.
So meanwhile, Anna is sorting his technical issues. So let me introduce the 3 speakers, and that way we can save time. So in these sessions, we have three speakers. So first speaker is Professor João Batista Garcia. He's Associate Professor in the Federal University of Brazil and the head of the pain and the palliative care in the University Hospital. He's the Chief of Pain and Palliative Care Service in the Cancer Hospital and the President of Latin America. He's also served as a ISP counselor, work as an anesthesiologist and pain and palliative care. So thank you very much, João, for this panel. Our second panelist is Taqdeer Muspa. He works in pain clinic and runs the acute pain services and do some interventional procedures for chronic and cancer pain at Hasanuddin University Hospital and Wahiduddin University Hospital. It is the biggest teaching hospital of the Eastern Indonesia. He runs anesthesiologist training program and the pain management consultant program. Our third panelist is Dr. Abdullah Kaki. Thank you very much, Dr. Abdullah Kaki. So he's a professor and consultant anesthesiologist in pain medicine. He is a director of pain clinic, faculty of medicine, King Abdulaziz University, Jeddah, Saudi Arabia. He's a president and founder of Saudi Society of Pain Medicine in Saudi Arabia. He's a president of Saudi Arabia Board Medicine and the Pain Fellowship Committee and the member of editorial board of Saudi Journal of Anesthesia. So thank you very much for all worthy, our panelists for this session. And I think now Anna is ready.
I'm back.
Thank you, Anna. Anna, I have introduced,
Sorry for
thank
this.
you. Not at all. I have introduced your three speakers, so
Yes,
please start your
thank
session.
you.
Thank you very much.
Thank you. Thank you very much. Sorry
Thank
very
you.
much. Well, we are going to start with a few questions to discuss with the panelists. The first question I have is about oncologic pain management. How does it change with pandemic situation? Dr. João Baptista?
Hello. It is an honor for me to be here today to discuss such an important topic. First of all, I would like to place Latin America and my country in the context of COVID-19 and cancer. In Latin America, we already have more than 1 million deaths from COVID and more than 32 million people infected. The number of deaths from COVID-19 in Brazil is around 552,000 people and represents practically half of the deaths in the region. Some factors such as difficult access to healthcare in several regions of Latin America, the high index of poverty, the low availability of clean water, and waste management contribute to exacerbate the pandemic's numbers. In LA alone, more than 1 million new cancers, up to 600,000 deaths occur each year, place a considerable burden on local health care systems. This is worsened by a large proportion of patients presented with advanced disease at diagnosis. The estimate of new cancer cases per year in Brazil is around 700,000. And of these, 6% will be diagnosed at an advanced stage. In this context, pain is a central phenomenon, affecting 70% of cases. Studies by the Lancet Oncology Commission show that 54% of the population in Latin America do not have health coverage or any type of access to it. In many cases, will suffer devastating symptoms before dying, even palliative emergencies, without infrastructure or trained staff for this purpose. Most people dying of terminal chronic diseases in developed countries do not have access to controlled medicinal products for pain management, and many of them died suffering from pain. Okay, all this was already a reality before the pandemic. What do you observe now? Early during the COVID-19 pandemic, surgical associations recommended postponing elective surgeries to keep capacity of health system. but also due to some evidence suggesting that cancer patients are at an increased risk of dying from COVID-19. In a Colombia study, patients with cancer have high mortality due to COVID infection if they have active cancer, metastatic or progressive cancer, and low socioeconomic status. According to a study carried out in the region, the number of chemotherapies performed in Latin America during the pandemic decreased between up 54%, depending on the country. Cancer surgeries declined between 28% and 70% due to global health crisis. In a cancer center in an epicenter of the pandemic in Brazil, in São Paulo, the total number of medical appointments declined by 45% in the COVID period, including a 60% reduction in the volume of surgical cases. Based on this data, what you observed in real life was a dramatic reduction in the number of patients who went to the pain services and hospitals, and after the pandemic began to improve, a large number of patients with decompensated pain conditions, in addition to new conditions to difficult pain control related to post-COVID syndrome, such as peripheral neuropathies, such as postoperative neuralgia, for example. Many patients also required interventional methods, such as neurolytic blocks for pain control. So the scenario is of a global worsening in the prevalence and the intensity of the pain.
Thank you very much, Dr. Joao. I have another question, but I think you have already answered it. That was, how do you think that COVID-19 affected the assistance of oncological patients?
Okay. Overall, over the past months, in order to mitigate the spread of COVID-19, in-person access to physicians was limited and predominantly moved to telemedicine. While telemedicine has been beneficial in maintaining contact with patients and continuing therapy, due to inability to perform a physical exam, it did delay and has created lag in appropriate diagnosis and treatment. In our region, we have a serious problem. Here in Latin America, we do not have enough access. There is a lack of access of the population to technologies that facilitate telemedicine. From this reality, telemedicine is more viable in large centers and is not possible to reach 1,000 people. Furthermore, diagnostic imaging all have had to be postponed, which may have delayed diagnostic and therapeutic proposals. Due to deferment of elective cases, patients who were currently awaited to undergo extensive surgery as laminectomy or total knee arthroplasty have their surgeries delayed. Physical therapy programs, which are an integral part of a multimodal chronic pain management, have been halted due to the COVID pandemic. Numerous patients who have had positive outcomes with physical therapy or aquatherapy, for example, have been unable to receive their therapy sessions, resulting in potentially worsened pain. With the offices closed, psychologists are unable to provide the necessary assistance, such as cognitive behavior therapy, coping skill, and manage stress. Stresses like financial loss, personal loss, anxiety, etc., all can take a toll on patients' chronic pain state, further exacerbate the symptoms. In a document published on its website, Latin America Federation of Association for the Study of Pain, FEDELAT, recommended the repeated filling of prescription of controlled substances, such as opioids and psychotropics, for more long periods than usual, for 6 to 90 days, to reduce patient visits to the healthcare center as much as possible. In Brazil, electronic prescription of controlled drugs were recently approved by the legislature. Provide the prescription are digitally validated. Another aspect, the resumption of elective procedures still means some patients may have to wait weeks to months for their procedures. Moreover, patients are still apprehensive about proceeding with elective procedures, and rightfully so, at the risk of being exposed to COVID. Additionally, many patients who initially had medical insurance lost their coverage and they were laid off by their job. This could further delay interventional or therapeutic treatment plans. So I conclude that the COVID-19 pandemic forced the pain specialists and the institutions to balance the risk of intervention versus benefits of pain, procedures, and therapeutic recommendations. And this all had very negative impact on patients with chronic pain.
Okay, thank you a lot, Joao. We are going to make the third question, that is, which tools have your services developed to cope the pandemic situation in oncologic pain patients? And we will ask Dr. Kaki to answer it.
Thank you, Anna. And good afternoon, Saudi time, good morning and good evening. I would like to thank the pain committee officer for giving me this chance to be part of this webinar. Now, just like to remind the audience and the panelists that we are approaching 200 million confirmed cases throughout the world of COVID-19 and almost 5 million passed away. So COVID-19 is a pandemic that affected all of us. In Saudi, we took the decision to fight the pandemic earlier. So there was a lockdown starting March 2020. And with that, of course, all the hospital and the health services was directed towards the COVID-19, which means that all oncology patient, if it's not real emergency, if he doesn't need that dose of chemotherapy or that surgery, then he will be postponed. They created a telemedicine in Saudi, and of course, to have a telemedicine, you have to be familiar with the digital era, and you have to have an access to that with a computer or a smartphone. Until now, we still have some illiterate people that they cannot do that. So on the other hand, to deal with this situation, actually, what we did, we promote certain patients to come to the hospital, doing the screening for them, ensure that they don't have any high temperature or symptom or sign of COVID-19, then using all the protection, face mask, gloves, and so on, they can enter the hospital, knowing that oncology cases, they're all immunocompromised. And a visit to the hospital might end with COVID-19. So that's another disaster that we faced, and we have to cope with it. On the other hand, we extended our working time, and instead of 8 to 5 p.m., we make it till evening time and reduce the number of patients per clinic. So this way, we reduce the crowdedness in the area and ensure that there's no spread of the infection if anything happened. So telemedicine and apps was developed, and then it was sent to the patient as a step to prevent the patient from coming to the hospital unless there's a real necessity for that, as they say, that chemotherapy or surgery. On the other hand, of course, the refill of medicine was another challenge that we faced in Saudi. And for this reason, we created what we call a postal service. That the patient will ask for his medicine through the apps, then the medicine will be sent to him. And in that situation, we face a problem with the controlled medication that we cannot send it through the post. So what was planned from the health services that the medicine will be sent to the nearest hospital to the patient. since Saudi is almost a continent, and he would collect it from that medical center or hospital and sign that he received it. Unfortunately, we couldn't change the policy of giving the medicine only for 1 month. The idea was to prescribe the medicine, especially opioid, for longer period, but it didn't work. And of course, some of the patients have no access to health service living in towns or villages. So that's another issue. That means that patient suffered somewhat of the pain. I think I answered the first question.
Thank you very much, Dr. Kaki. I have another question. Do you think that COVID-19 pandemic has deteriorated the quality of life of patients with oncologic chronic pain, Dr. Kaki?
Yes, of course. Since we don't have a proper assessment, you cannot assess a patient by phone. The psychological part, although there was a special line just to do counseling for the patient and to relieve their tension and their psychological problem, but that's not enough. The patient would like to come and see, especially pain patient. Depending on asking the patient, how bad is your pain, mild, moderate, or severe, or a numerical scale is asked, that will give an idea and will give us a chance to manage the patient. But of course, some patients, of course, as I said before, they have no access to the digital area. They have no access to the internet. They are unfamiliar with that. They are illiterate people. They don't know how to write or to read. So they cannot use the smartphone. They cannot use the computer. So this affected their management for sure. And on the other hand, the doctor were busy, most of us were busy looking after COVID-19 patients. And here you have to be careful with the personal protective equipment and covering yourself. You don't want to get infection. There was a lot of infection among doctor and nurses. Fortunately, in Saudi, it was limited. We don't have a lot of cases. Till yesterday, we almost 496,000 patients of COVID-19 confirmed, and the death rate was around 4,000. But even with that, the management of the patient was not ideal, not the best actually management, because the patient, as I told you, he used to come to the hospital, being examined, you listen to him, and he will collect his medicine and go. So this was affected. And on the other hand, because of the limited number per clinic, there was a long list of patients now waiting. And we'll try to fix that, whether for surgery, because we're only doing emergency surgery during the COVID-19 lockdown era, or we're doing the seeing him in the pain clinic and giving the medicine. Of course, if any patient with cancer need an interventional, what will happen that we admit him, take all the precaution, and we do them with a celiac neurologic plexus or any other procedure that's need to be done immediately, and there's no need to increase his suffering. So that was an issue. But of course, as a result of COVID, the patient management was deteriorated. Most of the patients, they get depressed because of economic reason, as Dr. Garcia mentioned before, and some of them, they cannot work. Some of them, they lock down, give them a depression. He cannot get out of his house. So that was another issue, depression and anxiety increase the pain. Pain per se will make him immunocompromised. So just imagine somebody with immunocompromised situation coming to the hospital, he will get the COVID-19, then he will go and infect the rest of his family. We don't want that. So this all issues that we try to fix and to deal with as much as possible. I hope that I answer your question.
Thank you very much, Dr. Kaki.
Welcome.
Well, now it's the turn of Dr. Tadkir Musba. I have this question for you about chronic pain management. How does it change with pandemic situations?
Okay, thanks, Anna. I think before I answer your question, I just want to give you an information that Indonesia is one of the countries that really affected by the COVID-19 in Southeast Asia. We are the #1 now in the mortality and also the case each day. So I think this is a very challenge. It's a big challenge for us in Indonesia to run the service in pain, and also in the same time we have to work with COVID-19. Just make sure your question about the chronic pain in this pandemic situation. I think that we will be back to the concept of the multidimensional phenomenon of the chronic pain, because the chronic pain, of course, have biological, psychological, and of course the social factor that can be contribute to the pain itself. And during this pandemic, I think I saw many patients in my pain clinic because I still open my pain clinic. There's a very big number of patients, and I think they have a very suffering because of our inadequate treatment in the chronic pain. We know that this pandemic situation make us very different than before because of there are very limitation for our activity. And if we talk about the chronic pain services, it's the bad news for all of us in as a pain physician, because chronic pain services is considered as non-urgent services by the hospital. So many outpatient cannot be come to visit the hospital, and like the Dr. Kaki said before about the interventional pain procedure that we can give to the patient is a little bit interrupted by the condition. But I just want to make a big point about the non-pharmacology approach. I mean that in the chronic pain, the non-pharmacology approach is a very big role. And we know that there is some problem of the limitation in this COVID-19 pandemic. You know that we are very limited in activity outdoor, and we have limited met with the friend or family. And you know that the chronic pain, the social approach is a very important. And why? Because of this condition in the pandemic situation, there is a very big problem of the patient with the chronic pain. So in my opinion, because of this condition, even the pharmacologic treatment that we can give the patient is limited in this condition, but also we can optimize the what we call the non-pharmacological approach. For an example, I give an example about how we make self-management skill for our patient for the chronic pain. It's really difficult if we don't have enough time to explain how they know their pain, how make it clear what the goal of the treatment step by step. It's very difficult if the patient cannot be come and face to face with us. So as conclusion of your question, I just want to say that we have a lot of trouble in a chronic pain management during this pandemic. Until now, we don't have enough power or enough management for the patient. And I think I don't know exactly how long that we can do like this and let the patient in chronic pain in suffering. I think that it's I talk, Anna. Thank you.
Thank you, Dr. Musba. One last question for you. Which of the tools that we have developed during the pandemic do you think that we will stay using with chronic patients? I'm sorry, but you have 2 minutes.
Okay. This is the condition of Indonesia, and I think we have to make it clearly that we have to make a balance of our health service risk mitigation and the patient right to manage, to treat, and to manage their pain. Because I give you the information in some pain clinic in Indonesia, there is no significant decrease of number of patients visit the pain clinic, because they are really suffering, especially for the pain clinic, also with the oncological pain. They are pain suffering, and they will looking for the treatment, even they know that there is a risk to come to hospital. So I think that we have to face with this both condition, the people or the patient who can come to the pain services, or the people or the patient maybe fear to come to the hospital. So we have to face with this both condition. So it's clearly that we have to open our pain treatment, but of course we need to modify our services, as Dr. Kaki say about how we make a good screening before the patient comes, and how we use a proper protective personal equipment, and how to we support by the hospital for the risk of mitigation, So I think this is very important that we have to still open the pain access or pain treatment, because we also run telemedicine, but I think Dr. Kaki already said that there's very not all the part in my country can optimize the using of telemedicine. Because of we know even there's an advantage of the telemedicine, we can patient triage which one we can decide it to come to clinic, which one just by appointment with telecommunication consultation, or maybe the patient needed some pain procedure. But it is can be done if the telemedicine run well, and I'm not sure that in my country all the community can optimize this telemedicine. So what we have applied in some of the pain clinic in Indonesia, that we just make a simple telemedicine. I mean that we can use the phone call or the video call, and the patient relative come to the pain clinic. If the patient cannot be come, and they will be asked by the phone by the doctor, and looking for some information from the relative who visit the pain clinic, and after that we decided to give some medication, or maybe give an advice of the some non-pharmacology treatment, as I say before, that how we teach and advise them to make a self-management skill. I think this is my it's my answer, Anna. Thank you.
Thank you very much. Well, the time is running fast, so we have the last question that is for all the panelists, and it is what we have learned from this pandemic situation in our management, in our pain management for oncological and for chronic pains. I don't know if who wants to start.
I can start.
Okay, show out.
Okay, we have learned a lot, and we have learned to highlight the significant impact of COVID-19 pandemic had, and probably continues to have on access to chronic pain relief. The quantification of such an impact is essential to inform and prioritize interventions in provision of future waves of the pandemic or ulterior similar disasters. A priority would be, of course, to maintain continuity of care for individuals suffering from chronic pain despite the pandemic. In the case of patients with chronic pain, telemedicine can be a valid strategy for outpatients follow-up even after the pandemic, as it presents excellent benefits relative to costs and satisfactory results. However, it's necessary that the governments of low-income countries, as in Brazil, improve access to this technology. Each pain service needs to establish a screening model classifying patients according to severity. Urgent case which require face-to-face assistance need to be treated in a way that minimizes the risk of COVID-19. Infection prevention, we have learned a lot, and control measures must follow the recommended government guidelines. Particular attention should be given to patients who use opioids and are at risk of misuse. It's not a reality so big in Brazil, but in other countries, I think it is. Non-pharmacological approaches and pain education should be maintained, consider the use of telehealth. And another undeniable and important aspect of learning was the personal change that this whole pandemic has brought to all of us. The great appreciate of the human being, the reduction of barriers such as prejudice, and the greater strength between peoples of different nations. It's my impression.
Anna, can I?
Okay. Yes, Musba, yeah, we are run out of time, but
yeah,
I give you.
Just, yeah, we covered most of the things, but I think what we learned is how to deal with infection in a better way. You know, how to change our practice, how we behave at home and in the hospital. And the telemedicine was created, and I think it will stay. It's a way for us to utilize, to assess a patient. We need to develop certain tools to assess a pain patient by telemedicine to communicate better. We have to change our bylaw, our policy and procedure regarding the opioid and the controlled medication, and we could give it to the patient for more longer period than usual. And we have to develop a way to support the patient psychologically, whether due to economic reason or disease reason. Thank you.
Okay, just a two sentence. Yeah, just a two sentence. I mean that what we are learned is so we have to adapt it in this situation. Yeah, because of we know that this is very big issue about the COVID-19, and the tool of yesterday, of course, cannot be solved all the problem of today. And our big problem is how delivery pain management, but we have to prevent ourselves and our healthcare provider from the functional collapse because of the COVID. But the patient have a right to manage and treat their pain. So what the important thing that I learned is we have to look in for the benefit of benefit versus the risk. If we do some of the pain procedure, if we want to visit face-to-face with the patient, we have to look in for the benefit versus risk. We cannot be stop our pain treatment, stop our pain services and make the patient will suffering, because all of us in here sure that the pain is a very suffering for all the people. So I think this is my opinion about what we are learned. But I think all of us here have to make a statement that pain management is not an elective services. It's not an non-urgent services. It's an urgent services in a hospital. Even there is some. That's why there are so many guidelines that can guiding us to give a pain management in this during this COVID and pandemic is a safety and comfort to all the people. I think this is my last opinion, Anna. Thanks.
Well, okay. Thank you very much. Sorry, we have 3 minutes more, but I think it's worth a while. Thank you very much. Gauhar?
Yeah. Okay. So, Anna, so do you have any, we have 3 to 5 minutes. So do you have any burning questions in your chat box? No. Or if you, any other panelist, if you want to ask from this panelist, any question, burning question, anything else? So if no, then thank you very much, Anna, for moderating this session. And thank you very much all our panelists. And, I think the panelists are Dr. Muspa, Dr. Gracia, and Dr. Kaki. And they were very clear about how they actually face these challenges and how they made the strategies in their own countries, considering the highly prevalent problem at that particular time. And telemedicine is coming up as a consensus that we have to keep facilitating or keep enhancing or keep promoting the telemedicine, because these days are not going so soon. So we have to have an alternative. So I think for that, I'm closing this first session, which is about chronic and cancer pain. And now I would like to invite Dr. Lutfuz Zaman, who is the moderator of the next panel, Dr. Lutful Aziz. Dr. Lutful Aziz, a very brief introduction about him. He's a consultant and coordinator, Department of Anesthesia, ICU, Pain Medicine, and Evercare Hospital, Dhaka, Bangladesh. He is PhD in Anesthesia and Pain Medicine from Wakayama University, Japan, and from FCPS from University of College of Physician Surgeon in Bangladesh. He's associate professor in Bangabadhu Sheikh Mujib University. He has a special interest in pain and regional anesthesia. He's a founder, member, president, and currently the immediate past president of Bangladesh Society of Pain Medicine. So I would invite Dr. Lutful Aziz to run the session, which is very interesting, and all of anesthesiologists are, eagerly waiting for that. Acute post-operative pain management in COVID positive patients, a challenge during pandemic. Dr. Lutful Aziz.
Thank you, Gauhar. And I'd like to thank you, the WFSA, for arranging this webinar, which is a time tested and it's very required nowadays. So I'll introduce the panelists. I have 3 members of the panel. Dr. P.N. Jain, he is from India, consultant palliative medicine, formerly professor and head pain division, Department of Anesthesiology, Critical Care and Pain, Tata Memorial Center in Mumbai, past president, Indian Society for the Study of Pain, and he has an Pain International Cancer Fellowship in Memorial Sloan Kettering, New York. He's a WHO expert reviewer on opioid for chronic pain member Developing Countries Working Group, IASP. And then we have Dr. Sean Chetty. He's an anesthesiologist from South Africa and head of the Department of Anesthesiology and Critical Care at Stellenbosch University and Tygerberg Hospital in Cape Town, South Africa. President of the South African Pain Society and executive member of the South African Society of Anesthesiologists. His clinical interest in pain extended over both acute and chronic pain. His PhD was focused on pain in the obstetric population of patients. He is very keen interest in expanding pain education, particularly in low resource settings where pain is often forgotten. Then we have Stephen Gatt, Professor of Anesthesia and Reanimation, Udayana University, Associate Professor Anesthesia, Critical Care and Emergency Medicine, University of New South Wales, Senior Staff Specialist, Royal Hospital for Women and Prince of Wales, Sydney Children's Hospital, and Consultant, Prince of Wales Hospital, Private Hospital, Emeritus Lifetime President, Obstetric Anesthesia Society of Anesthesiologists, ENIA. And he has a beautiful introduction. Stephen Gatt hails from Sydney, Australia, where the global COVID-19 pandemic has had minimal impact on health services, with the exception of public health, where there is only a small influence on acute and perioperative pain management, and where occasional waves of outbreaks have been treated highly successfully with immediate but extreme societal, all of government, almost draconian initiatives. Nevertheless, as not only the anesthetist and intensive, but also one who holds fellowships in medical administration and health service management, Dr. Gatt is profoundly interested in COVID-19 alternative management and is completing the last chapter, The Delta Variant Endgame, a book entitled 3 Vessels and 3 Castles, Eradicating the Coronavirus Epidemic Immediately. 10 million people at a time. So I'll start with a few questions directed to all the members. So my first question would be to the panelists, how the COVID-19 pandemic has affected the routine surgical cases requiring post-operative pain management in your country. I'll start with Professor Jain from India. Jain, you are muted.
Okay. Yes, hi, hello, good evening and good morning to some of the country fellows. So I work in a tertiary care cancer center. You can see the building behind. And we had very bad COVID pandemic. As you know, we were having 2 lockdowns and 22 million deaths by the COVID alone. 1,500 physicians died during this. So we had very colossal disaster in the form of COVID-19 here. In cancer, let's say considered a semi-emergency. So we continued our surgeries, even routine cases where we performed the COVID test within 48 hours and they were the long procedures. Staff was low and due to lack of the transport across the country, people were not coming to the hospital, but we ran some 50% operation theaters. And that is how it is. So post-operative pain, as far as that is concerned, that was also equally affected because nurses were not there. 50% of nurses in the hospital were absent. And doctors were also fewer, but they were interested with the job of anesthesia. So nobody used to go to the ward. Though COVID isolation wards, quarantine wards, they were separate in the buildings. So it was not mixing each other. But certainly when I gave anesthesia to some patient, and second day report came that he came positive. So that is how I was also quarantined, and sometimes like that. So our residents, about our 30 residents were also quarantined. Some were isolated. Many more operation theater technicians were all affected. So post-operative pain management, of course, took the back seat. However, whatever protocols are there in a hospital that patients are getting round the clock paracetamol. Of course, NSAIDs was avoided, but if the patient has got a thoracic surgery or abdominal surgery, certainly we passed thoracic epidural as we were giving, and infusers were filled for opioid and local anesthetic around the clock. But somehow, when some patients um, uh, were not actually refilled properly, and they emptied the Baxter balloon pumps we were using, we were emptied in 4 a.m. or 5 a.m. and then we are taking the round at 10 a.m. The patient were in severe pain. So these glitches were of course there. So I would say that pandemic severely affected the post-operative pain management in our country, because in our country the acute pain services are very little. About 95% patient in the hospital do not have the acute pain services. Over to you.
Okay, thank you very much. This is one side of the story, and now we can go to the other side of the globe, Australia, where the pandemic didn't strike that much. But what was your views on, Stephen? What was your views about the routine surgical cases requiring post-operative pain management?
Thank you. First of all, I'm delighted to be here with you this evening. Initially, when the pandemic first started and was not characterized in any way, there was really a panic in this country. You were seeing all the images coming from Wuhan and from Bergamo and then from New York City. And we thought, this is what's going to happen to us straight away. So we went into a very wide-ranging nationwide lockdown. The streets were deserted like happened in most countries. And all emergency, non-oncology and non-obstetric cases were canceled for all hospitals. So only the emergencies were being done. Now, what happened next, that was quite interesting because there was such rigidity established on all states. Most states eventually had no cases, and the only state that was affected by this was us. And what happened initially was that there were quite a few number of cases. Again, compared to what you've seen, this was nothing. We would be seeing, we had with 8 cases, on 4 cases, New Zealand at one stage closed down the entire country and sent everyone to Telegram with 4 cases, and 3 of them were in one family. This is the sort of scenario we've been seeing over here. But New South Wales, my state, was the one that was affected the most. We were doing extensive testing. For example, this morning, in my state alone, with 85,000 PCR tests, and we only have 100 cases yesterday and 180 cases yesterday and 205 today. So effectively, the numbers are nothing like what you've been seeing in India, in Pakistan, in Bangladesh, and all these other places, and likewise in Latin America. However, what happened, that the great fear that something was going to happen disaster to us sent everybody into the panic, and especially the surgeons. So when it came to post-operative pain, the surgeons wanted to find a way of making sure that if we ever got out of this, that we would still be able to operate and that we would never be affected again. So the changes that have happened in acute pain management have been absolutely incredible. Why? Because of fear, not because of the pandemic itself. We created great redundancies, for example, and the ability to create surgency. The crisis never eventuated. And as we tend to return to normal was planned, for example, many of the surgical subspecialties decided to go their own way with their own hospitals, doing nothing but eye surgery, nothing but orthopedic surgery, nothing but a very specialized thing, and these were going to be COVID-free hospitals. So there was an enormous change now, not only in the surgeries, but also in the pain management. All the COVID-free hospitals were put onto incredible stress to make sure that not a single COVID positive patient would ever enter that hospital. Questionnaires, phone calls on the day before you arrived at the hospital, that no emergency is being treated at all, PCR testing for everybody before you come to surgery, and so on. The outbreak in New South Wales within a month and a half was gone. And since then, we have had nothing until 6 weeks ago. So when we experienced a flare of this time Delta strain, we are back in full lockdown again, but the number of actual cases remains very low. And we have allowed most elective cases to carry on in these privatized centers. Routine surgical cases have been impacted to no great degree, but the reaction, once again, from the angle of elective cases has been very dramatic. And so what we've done is we've put in all the things that we wanted to put in beforehand, and these have been put aggressively into place. I think I'll stop there because I think there'll be further questions later on. And
now, Sean, because I don't know, from the reports from the African continent is so limited, so we don't know actually what is happening over there. So can you enlighten us on this matter, that what about your routine surgical cases and the post-operative pain management over there?
Thank you very much. So while I'm from South Africa, I think it's important that I contextualize the impact of COVID on the African continent, because we're a massive continent. We occupy a huge proportion of the world's land mass. And if you consider that the developing world represents the majority of the land mass in this planet, almost the entire continent of Africa is actually considered to be less developed or least developed. So we know from the WHO stats that a developing country is one where the people have a very poor standard of living conditions. And it's defined by three factors effectively: life expectancy, knowledge and education, and standard of living. And this is measured by the Human Development Index. So if a country has a low stats in all of these factors, then it's considered to be a developing country. Now, in Africa, there's about 1.2 billion people that live on the continent. And most of our countries have an underdeveloped healthcare service. The vast majority of our health burden on the continent is actually, prior to COVID, is related to infectious diseases such as HIV, tuberculosis, malaria. And coupled with that, there's a critical lack of intensive care resources across the continent. So when you take all of that into account, you can understand the impacts that a disease like COVID is going to have on resources that are so limited. So in terms of statistics, Africa, surprisingly, I think surprising to all of the world and surprising to us, only ended up, or at the moment, has a total of 4 million cases of COVID-19. Of these, 116,000 deaths. And this is surprisingly low considering the healthcare systems within the country. So one has to question, is our stats low because of a real low rate of infection, or is our stats low because our services don't allow for adequate reporting? So in my country, South Africa, we unfortunately account for just about 50% of the infection rates within the continent. We're sitting at around 2.4 million cases and about 71,000 deaths. When I listened to what Stephen said, I was extremely jealous. The fact that there were no physicians and nurses that have died. And I think our infection rates or our effects were very similar to what Jane had talked about. So our journey through this pandemic has been different from the first wave to what we're currently in our third wave. And in the first wave, we were very much like what Australia did. The entire country shut down. The economy of the country shut down, and that was for probably about 5 weeks. And you can understand that in a developing country with a developing economy, to shut the economy down for that period of time, it has, while we really controlled COVID well in that first wave, the socioeconomic impact has been massive. And there's been huge arguments about the fact that while we are saving people from COVID, people are just going to die now from starvation. In terms of how we've progressed, our lockdowns have been less severe, but our impact in hospitals have probably been similar with each wave. With every wave, we slash almost all elective surgeries, and like Stephen and Jane had talked about, we just would continue with obstetrics and with emergency surgery. Even cancer surgery in some cases are postponed. So the impact in terms of our surgical population has been huge for the non-emergency cases. Unfortunately, South Africa also deals with an epidemic of trauma in terms of violence. And so throughout, every time our lockdowns are lifted, the violent crime or the violence goes up, and the trauma associated with motor vehicle accidents, gunshot wounds, and stabbings increases, putting a huge burden on our hospital services. But throughout all of this, we've had to continue, and we've had to just try and make sure we manage infections within the hospitals, but our life in the emergencies has continued.
Right, thank you. Now that we know about the post-operative pain management in different countries, so I'd like to ask again all the three panelists, what were the commonest pain modalities used for post-operative pain in your countries? Was it epidural, plexus blocks, or IV narcotic, or simply oral drugs or everything? So I can start with Jane again. Dr. Jane.
We for all thoracic surgeries and abdominal surgeries as a protocol, we are having thoracic epidural analgesia. And typically we are having 30 to 40 patients per day, but during pandemic, of course, 50% was compromised. So about all the patients as a protocol are put epidurals, and now we are increasing the regional anesthesia also. So tab blocks and brachial plexus blocks and other PEC blocks, they are all increasing now. But however, if the patients are not fit for any like septicemia or something like that, as COVID patients are ASA grade 3 and they are sicker patients, so then we are avoiding epidurals in such patients, and we are giving just IV tramadol and IV paracetamol around the clock, thrice a day to such patients, and then they are managed in the ICU by the same team there, and acute pain services contacted when there is a crisis or some severe pain, breakthrough pains are there. Normally, we are having epidural services going on for all routine cases, elective cases.
Which is regional, so you shifted to regional.
Yes.
What about Stephen, in your country, what did you do? Because you didn't handle emergencies as much as you said before. So what were the modalities or procedures that you have done for acute pain, post-operative pain management?
Again, it's funny because once again, we're a bit lucky over here. Already Australia-wide, there was a huge movement already to go to major neuraxial blocks, to go to multimodal intraoperative analgesia, to go to multimodal post-operatively with tramadol and tapentadol and ketamine and paracetamol and NSAIDs and all sorts of these things that were mostly available already to us intravenously. So we're using them quite frequently for post-operative pain. Now, however, there now was the added thing of what do you do if you fear COVID coming to you, even if you don't get it. And of course, what became the norm now was regional anesthesia wherever possible for everything in all specialties. Every specialty eventually went and did their own thing. For example, in obstetrics, it became intrathecal and epidural opioids, epidural PCEA, patient control, that is, already in frequent use for the last 10, 15 years. But every specialty chose its own preferred method with opioid sparing possible. Of course, during the COVID pandemic over here, the major issue was the other pandemic, the USA opioid pandemic, where everybody was now trying to do opioid sparing, not giving anybody any oral opioids post-operatively, if preferably. And there was a feeling here that opioids from now on became adjunctive therapies and not the mainstay for pain control for trauma, for post-op pain, and so on. So regional anesthesia for everything wherever possible, and then adding all the other things, the infiltration, local anesthetics into knees, for example, epidurals and continuous regional anesthesia peripheral blocks for peripheral limb surgery. They replaced the opioid PCAs, the intramuscular or intravenous intermittent injections. All of those had already gone mainly, but now even more so. And the surgery itself became progressively more non-invasive or minimally invasive, with minimal contact with the staff for fear of perhaps spreading COVID, full protection and precautions. And, the pain modalities were now combined with very early other things like early mobilization. For example, it's 6 to 8 hours for bilateral knee replacement. You're out of bed and walking. 6 to 8. Early discharge. Same, for example, for a coronary artery bypass graft, same day surgery and a 3-day stay in hospital. So basically get people out of hospital as quickly as you possibly can. Extensive rehabilitation, starting usually the day after surgery for hip replacements, for example, and so on. And then after surgery, a lot of the post-operative pain was now being shunted out to clinics, to the doctors' rooms themselves, to these smaller hospitals, and to specialized rehabilitation clinics all over the country. And so basically, we stopped using oral opioids mainly. We stopped using anything containing codeine, but otherwise, everything else just exploded suddenly. So for us, it was almost Santa Corona. Thank you very much.
So again, regionality here. So Sean, what about in your country? Which procedures did you do most?
So as I said, we dealt mostly with emergencies and obviously obstetrics. And in the height of things, all elective procedures would have been stopped. But we must remember that in my country and throughout of Africa, pain has always been viewed as a luxury by regulatory authorities, whereas us as the clinicians certainly see it as mandatory. And I think that its pain management suffered the most. As a result, it was one of the greatest victims of the COVID pandemic, because all of a sudden, what little resources we had prior to the pandemic have all been now redirected into trying to save people from this pandemic. So when we had to operate, and the aim was, like with Stephen, we would try and, certainly from an anesthetic point of view, do regional anesthetic techniques. But once they got to the ward, there were no epidurals, there were no plexus blocks, there were no catheters, because at the best of times, we wouldn't be doing that. And certainly in a country like mine, where most healthcare happens in regional and district level hospitals, they've never had access to that. In the academic centers, again, we knee-jerked and went back to the old way of writing up scripts that the nurses can administer, because people were going to do everything they could to avoid actually going to the wards and being in contact with an at-risk patient.
Okay, great. So that was the scenario in your place, where mainly the oral prescriptions were mostly used, right? So again, when we are discussing all these, we came across the word acute pain services several times. So my next question would be to all of you: how do you think that acute pain services in your country cope the pandemic situation in surgical population? So start with Sean. Sean is here already.
So acute pain service certainly in my country, and I would dare to speak for most of my counterparts across the continent, is a luxury. So certainly, and I work in a big tertiary academic center. We don't have a dedicated acute pain service, but rather have the anesthesiologists who go and deal with this, but not as a separate entity. It's your case. You've got to manage it afterwards. So even prior to COVID, we were struggling with acute pain services, and as I explained on how the pandemic impacted the management of pain, so in the general surgical population, you can imagine without an acute pain service, it made it even worse.
Okay, So, Stephen, what about in your country? Did acute pain service suffer?
No, I think again, we did exceedingly well. Because of this tremendous fear, we introduced this huge, this fear of being paralyzed by a disease that everywhere else had caused such havoc, that we introduced incredible redundancy within everything we did. I was asked to put in an additional 18 intensive care beds. In that first year, we used them twice. So we used those beds actually twice, on 2 occasions only in that whole time. We produced such complex, such extensive protocols that in the end, this ended up being a gross overreaction on our part. And everybody here complains continuously, like Sean's people complain about what's this doing to is it all worth it? All this destruction to the economy, for example, right? So we've done very well. And again, by having prepared for every eventuality, we improved our pain services in many ways, and especially we improved our pain delivery in every service. For example, we've been talking about a little bit about telemedicine for chronic pain. This became the norm. It wasn't even telemedicine. You got called 2 days before surgery to make sure you were well. Then you got a questionnaire the day before surgery. On the day of surgery, they called you again in the morning, is everything all right? And don't forget to come to your appointment. And post-operative is almost the same. Your surgeon would call you, your anesthetist would call you when you'd gone home. So it wasn't through telemedicine. Okay, the government allowed all GPs, for example, to start charging as though they were doing a face-to-face consultation, which helped dramatically because the GPs now, even the GPs were starting to follow their patients. And it was everything used. It was social media, it was Facebook, it was Twitter, it was everything that you could get on to make sure that no patient fell through the net. And I think we'll probably see that this will continue for a long time in our country. I hope we'll never have to use all the protocols and the guidelines and the equipment and the hospitals new beds that we've used. In the community, for those in lockdown with post-surgical or acute pain, we indeed targeted something unusual that hasn't happened in most other countries, I think, and that is that a lot of people who are in lockdown tend to catastrophize their pain. So we targeted that as not letting people catastrophize how painful it is. I think for us, there's a great realization that COVID itself will increase pain. After all, it's a cytokine, interleukin mediated type disease, so that these people probably have more pain than usual if they're positive, right? And for those who become positive or develop disease or need surgery, well, again, the solutions were quite simple. And there were very few of these. We developed strategies, isolation room surgery, and managing them in certain hospitals and not in others. We didn't have to do a lot of those sort of things at all. So this thing has taught us an enormous amount of stuff. For example, in many countries, you'd have the old Mother Hubbard problem of opening the cupboard and finding you got no drugs. Whereas in our case, we stockpile such huge numbers of pain medications and so on. I don't even know if they'll survive into being used before they're out of date. You know what I mean? It's that sort of almost wasteful management, really, if you think about it. On the other hand, it's worked well.
That's right.
Again, the population has been very united. If you tell them to go into lockdown, and we're currently in a 1 month, 6 weeks almost of lockdown, for what? Because we have a couple of hundred cases. It's
yes, that's the condition of different countries in this COVID situation. So, Jane, you were talking about suffering of the acute pain services in your surgical population. So I'd like you to answer on this, and also, can you add that what do you think that has acute pain services deteriorated for COVID positive patients? So if any COVID positive patients came with acute pain, do you think that has hampered their services to them?
We in India are having about 550 medical colleges. And I can say maybe that even 1% would have or 2% would have the acute pain service. It's a luxury, as Sean has already told, in Africa. So here, only the very big hospital, corporate hospitals are having acute pain services. We started our acute pain service in 2002 when I came back from US after my fellowship. So we are having a very vibrant acute pain service where there is a nurse being provided and there is a separate team of resident in the night and consultant, resident and nurse take the round of the whole hospital. So we are having 40 patients daily on our acute pain service. Maybe that 20 patients are on infusers, 10 patients are on PCA pumps, and some are on continuous regional anesthesia infusions. So it's a vibrant service. Of course, nowadays, 40,000 positive cases are occurring daily in India. 40,000 patients daily becoming positive here, though deaths are 500 daily here. So, but however, our hospital receives 1,000 patients of cancer daily here in tertiary care center. Our OPD is full and as usual going on regarding acute pain service. So acute pain services are, we have done a survey in 2016 in India, where we have sent about 4,000 emails to various hospitals and we found only 150 acute pain services were functional. Rest other had no protocols, no staff, dedicated staff for that. So you can say that maybe that was 5 years ago, but maybe that 250 or 400 or 500 acute pain services may be going on, but they are, I think, rudimentary and they don't have any protocols. We are hardly, I can see any presentations in our national conferences on acute pain services. So we started in 2002 and we have published a lot of literature on acute pain services from this side. Of course, our acute pain service suffered due to lack of dedicated nurse, which were given to us. Now she is back. But in between, during lockdowns, of course, that nurse was taken away and that was busy in the managing the wards or managing the chemotherapy, managing the other places. In the COVID, a lot of nurses have gone, 20% nursing staff has gone into COVID isolation and quarantine wards. So our nurses were not there. However, our resident, we are having about 30 MD registrations every year in this medical college. We are this hospital with medical colleges actually facility. So 90 residents for doing MD and 30 registrars. So 120 resident staff is there in our medical college. So on that we run this acute pain service. And of course, all the protocols were followed, but certainly some glitches are there when that lockdown is there and all that.
I have to stop you here because we are running short of time. So we have one last question to all the panelists. What did we learn from COVID-19 pandemic situation for acute pain patients? In short, maybe in 2 to 3 lines. Stephen?
Well, I learned a number of things, a huge number of things. First of all, I learned that nothing clears your mind quite as well than knowing that you're going to be hanged tomorrow morning. Armageddon was on its way. And so this was confirmed on the news from all over the world, and it galvanized everybody over here into action. The second, I think I learned was that dollars, real money, flows rapidly into the health system when all the community feels threatened. Now, Australia already spends 20% of its GDP on health. It is the biggest employer in the country, right? But whatever we wanted, ventilators, N95 masks, full PPE equipment, it just kept coming and coming and coming till we've drowned in it, right? It was deflected away from defense, from business and trade, from property development. Everything was going to the hospitals. Now, all the things we wanted for a very long time suddenly got accelerated, even if some were not eventually blindingly successful. We give it a try, and we tried everything. Governments can be controlled in our country very effectively by strong public health and by health, hospital, and community services, especially when you have an infective pandemic of this magnitude. We started talking over here of Santa Corona. I'm not joking about this. It brought much political unity. Both sides of parliament were suddenly going in the same direction, and they were driven by the health services. That it taught me that you can actually control a disease if you have community cohesion and unity of purpose. That, you know, lockdowns in our case have been very effective because they were done with for no good reason, almost sometimes, but it gave time for the public health services to. And the last thing I learned is that good pain management can only be achieved in a hospital if all the other arms of whatever it is, trauma, surgery, obstetrics, labor and delivery, unless they are coordinated, then you will never achieve good pain services. You have to have your surgeon, your obstetrician, your pain nurses, your pain services, all working in so that surgery, anesthesia, PACS services, post-acute care, recovery, rehab, all of them have to be on the same page. That's all I have to say for this last question. I thank you very much for listening to my argument.
Thank you, Stephen. So, Sean, in short, what did you learn? Your country.
I think I've just learned my greatest lesson from listening to Stephen is that, and my lesson is that the lessons learned between the developed and the developing world are so vastly different. In my case, and I think for most of my compatriots across this African continent, I think the lesson learned was that pain was one of the greatest losers in this pandemic, because all resources, the limited resources that we had, was actually directed to saving patients, and what little we had for pain was just moved away almost immediately.
Right, absolutely. Jane, your learning points?
Yeah, of course, during this pandemic, we have gone through a lot of strict adherence to the protocol, and of course, monitoring increased. So, many protocols have been made during this, and we have become more stricter, more disciplined. Nurses have their own protocols, doctors have protocols, frontline workers have protocols. So, entire hospital has gone on protocol spree. I can say that in post-operative ward, then ICUs, everywhere there are forms are coming, there are flyers and a lot of computer material on that, how to discharge this patient, how to shift this patient from one to that ward. Telemedicine has come in a very big way. Of course, opioids cannot be prescribed on telemedicine. So all these things are become very much improved. But of course, we were overwhelmed with the COVID. So we could not cope up with this. Our healthcare system is actually much needed in situation. So too many patients, and we were overwhelmed. I can say that. Yeah.
Okay, thank you very much. Thank you, all the three panelists. Now, I have one or two interesting questions, but Jane has already answered one. One question from Carolina. How did your patients acquire prescriptions for controlled medications such as opioids during confinement? So Jane has already answered that with telemedicine, it's not possible to have the opioid given. So anything from Stephen or Sean about this, telemedicine and opioid?
Is she talking about obstetrics only or everything else?
For any pain.
From Carolina.
All right.
For what? For acute pain or for obstetric pain?
She didn't mention anything. Just
okay. Okay. In that case, the answer is very simple. You know, in our case, prescriptions were still available anyway if you wanted them. But what happened with our case is that with all medications, if you wrote a script and you scanned it and sent it out to a pharmacy, it would be adhered to and used. But you had to promise, of course, to then send, and there would be a personal conversation between a pharmacist. In obstetrics, of course, this is not a question at all, because everybody in Australia delivers in a hospital. Even Aborigines that live, you know, thousands of miles away are flown in by helicopters and so on, and brought to the main hospital to deliver their babies, especially if they're high risk. So very few home deliveries at all. You know what I mean? So in obstetrics, all the opioids that are needed, even the intrathecal ones and the epidural ones and so on, all of the SA drugs are immediately available in the hospital, all hospitals.
Okay. And Sean, in your country, what did you do?
My interpretation of what Carolina's question was around the chronic pain access, and so our services essentially in the high lockdowns, our chronic pain services shut down because they were deemed to be non-essential. But in the second wave, we pushed back really hard, saying that these patients you cannot withdraw this type of service. Because of withdrawal and because of the suffering of the patients, and so we've been able to still see patients on a very limited basis in the clinics. So patients, the regulations around access to opioids did not change in South Africa. They were still as strict as they always were, but it just meant that we had to see patients in person, but in order to safeguard both the patients and the healthcare workers, we decreased the number of patients that could be seen at a clinic at any one time.
Okay, thank you. Thank you. We are at the end of this session, I guess, my session. I'd like to thank Jane, Sean, and Stephen for participating in this wonderful discussion. Thank you very much, WFSA, and thank you very much, Gauhar. Over to you, Gauhar.
Thank you, WFSA.
Thank you very much, Lutful. I think it was a wonderful session, and I think people are very much interested knowing what are the different experiences in different parts of the world. And I'm really thankful to Professor Stephen Gett sharing the experience of Australia, which is entirely different compared to the Professor Jen Parmanandan, who's in India, and he's really facing a challenge in the recent past, and Professor Sen Shetty. So thank you very much. It was very good to be here. So I think we have a short, we are running short of time. So I would request Claire, the last comments, because we are finishing in 8 minutes. So Claire, do you have any comments or burning comments for this session? And say goodbye and thank you on the behalf of the Pain Management Committee of WFSA. So over to Claire.
Yeah, so thank you all very much. It was a fascinating sort of whirlwind tour really around everyone's experiences. I mean, one thing I'd say from my experience is the variety of things that have happened has been extraordinary. And I think even, we heard Stephen's reports on high income countries, but that was incredibly different to the experience that I had in a country that was very affected, and our pain services were completely decimated as we moved everything into COVID work too. So a huge amount of variety, but also, of course, so many similarities. And one thing I was really struck by was the number of people who highlighted how this has only really amplified the problems of the disadvantaged groups. And, whether it's access to COVID treatment in the first place, access to treatment of other conditions, getting lower priority of vaccinations, and of course limited access to digital technologies. I think it has certainly across the board made only worse any problems for disadvantaged groups. But yeah, thank you all so much for taking part, to all the participants for giving up their time, to all the panelists and moderators for putting a huge amount of work, I know, into making all this run smoothly. Obviously to the WFSA and the team there, especially Jay. Finally, of course, to Gauhar for all your fantastic organisation with this. I know it's been a huge amount of work. Just one final plug, if I can. Gauhar, do you have the slide for the educational event? That's
Yes.
Thank you. At the WFSA. So we have an educational session running at the World Congress of Anesthesia for any of those of you who will be going. Thank you, Gauhar. On essential pain management. So this is obviously an educational program many of you will know that's heavily sponsored by the WFSA. So yes, thank you again everybody for your time. Thank you for a fantastic set of insights into this extraordinary time. And I hope that you will join us again for any of the future events that we have. Finally, back to you, Gauhar.
Okay, thank you very much, Claire, and thank you very much all my panelists and our moderators. And hopefully we'll see you in the WFSA Annual Congress in September and the future webinar. So thank you very much, and very special thank to Carolina for the member of the board committee who really supported this activity. Thank you, Claire, to give me this opportunity to organize this webinar, which is really needed, and we were really glad to see the different, sharing the experiences across the globe. Thank you very much. Thank you. Bye.
Thank you very much. Thank you all.